coffee break will be 20 to 11, so we have about 10, 15 minutes question and answer session now before we stop for the coffee break. Questions to the speakers? There's a question over there. Do we have microphones?
This is for Nicholas.
Yes, mother.
With energy, collecting your autogenous, are you mixing, I didn't quite follow, do you mix the autogenous you collect with your slow drilling with the PNG, if you will?
Yeah. So if we have a case where we're actually collecting the autogenous bone, put it into a receptacle and we'll basically replace it with small amounts of PRPF. If we want to, we can also activate it so it forms a more usable lump, if you like, and then apply that in one piece. But equally, you can use it as a slurry. Just your preference. And you can mix it with xenograft material as well if you prefer.
Okay. Well, so you don't necessarily just use the autogenous in the outside?
No, it's always kept. When the nurse takes it away from the site, it's placed onto a receptacle and kept moist with PRPF, with a fraction 2, which is the highest concentration.
Thank you very much.
Your question.
This is for Asher. Is there any, or did you find any connections, any connection between the paired implants, those 6 implants, and the angulation of your abutments?
I'm sorry, did I find any
connection between the paired implants, those 6 implants which failed, and the acute angle of the abutment?
No. I can't recall all of them, but one of them was as a result of overloading in a blood system. In fact, the second one was as a result of an acute infection that was present, which I didn't recognize because I didn't believe the patient that it was hurting. One of them was because it was again in branches, and the bridge broke because we hadn't put a metal reinforcement into it, and so that got overloaded. But no, I haven't noticed that with the angles at all. Remember that the transitional restoration that kept down the motion and at excessive forces. Thank you.
This is a question for Shane, please. When you put the connective tissue graft over the top of the implant on the top of the ridge, you suture it to the plate or femoral aspect, does the buccal flap then go completely over the top and also get sutured to there?
Absolutely. So you actually coronally advance the flap, which is the traditional way of covering the connective tissue. So you move to gingival junction, mucogingival junction, and you're going to reduce your width of carotidized gingiva under normal circumstances. But the effect of the connective tissue is actually to inhibit that coronal movement of the mucogingival junction. It's the sealing of it. And I think that most people who've actually done connective tissue grafting in a traditional manner for periosurgery, they are willing to accept the sloughing of the tissue. It does happen. It just turns white. It falls away. And it really is to do with not covering it. And so we've heard angiogenesis. The principal angiogenesis that is occurring is actually from the sloughing of blood, not actually from the lingual palatal attachment of the flap itself. And so you need to keep it covered. Angiogenesis occurs from the buccal sulcus, and that's how you keep it.
Just one question.
To Shane again. Your flap, the full thickness flap,
Full thickness flap,
all the way up to next up.
and
it is into the sulcus, it's to relieve the sulcus itself. So fibrous tissue is there, you will relieve it, and in that way you've got a fully mobilized flap. Again, that thing, a coronally advanced flap is what you want. You do not want any tension on that flap when you are actually securing it crestally. So the sutures you're using are crestal sutures, yes, but any relieving incisions that we've got have got apico-coronally directed suturing to actually stop scarring or withdrawal of that flap to expose, which will expose the actual connective tissue.
A question for Shane, today. Have you ever used xenographic like micrograft instead of connective tissue?
I've been really serious. I have, and it's gone in the bin. Okay? I've done enough reviews on mucograft. Have in mind that I used BioOts, and I used BioGuide. Mucograft does not work. Okay? It is very, very short term. And all of the reviews that I've done for different journals show no long-term success. Alright? 36 months later, you're back to the original situation. If you didn't have a width of paraxylized gingiva, for instance, you will have none after 36 months.
There's a question from Craig.
Thank you very much for 3 fantastic presentations. My question is for Ashok. Ashok, one of the concerns that many so-called authorities seem to have about immediate placement, this was reiterated quite thoroughly at so recently as the EAO in Dublin a couple of weeks ago, is that many cases, the likes of Boozer and Chen would allege 95% or more of cases in the upper anterior region are going to get early labial crestal bone loss, and this bone may even be present at the time of extraction and it's going to be subsequently lost fairly soon. And this will have implications for soft tissue preservation and potential implications for the future recession. Is your opinion that they're wrong in that this crestal bone loss doesn't occur in such a high percentage of cases, or is it that your opinion is that it doesn't matter?
I won't argue with anybody here, but what I will do is I will share my views on this. Firstly, I think some crestal bone loss will take place. There's no question of it whatsoever. That is why the highest success rates that we have in terms of aesthetic outcomes are with single teeth. And I dwelled upon the situation where you have 2 teeth adjacent to each other. Those are the most challenging, because that's when this is noticed, and it's the interceptor bone loss that causes the problems in conjunction with the crestal bone loss. So there's no doubt about that. You will also notice that our implants were placed more slightly towards the palate, leaving a little bit of space, allowing bone to form in that area. So that is worth noting. Then we also used, in the aesthetically critical cases, we used an aesthetic zirconium oxide development, which provided support for the soft tissue and connection of the hemodesmosomes, etc., directly to the abutment. So I think that's how we've compensated for it. There's no question in my mind that crestal bone loss of the socket edge does take place, as does the loss of interceptor bone between 2 implants that we place adjacent to each other. And that's when you struggle and use biomaterials to try to stabilize that area.
I was just trying to say that one of the things that is, I think, kind of critical is the high survival rates of immediate placements. And I think when we're truly objectively assessing whether or not we're getting success rates, it would be really important for us to be seeing long-term studies on the stability of soft tissues as part of our evaluation. And it is significantly absent, I think, in the literature at this stage.
I agree with you, and it is a matter of spending time, because recording the data, but it takes an amazing amount of time to actually go back and review it, compare the photographs that you've taken as you've gone along, and then taking it further and then going forward to publish it. And you're absolutely right, this is needed.
And this applies to delayed implant as well, Craig. There are very little studies looking at the stability of the soft tissues in the long term, delayed and immediately delayed implants. So it's an area that we really need to look into. There's a question from Eddie.
Can I just add one little comment to this discussion? And that is actually about patient selection. If you have a patient who has a thin soft tissue biotype, I showed a case there that was stable, single tooth, and if you have a patient who has a thin bone biotype, that's a significant difference. And then you need to assess that. And with thin biotypes, you will have difficulty with whatever procedure, whatever technique that you use, even if it's a non-linear. So just a thought.
Absolutely. I'm glad you highlighted that because you touched on it in your presentation, and you said that your prerequisites for selecting the implant was the intact buccal plate and good biotype and essential. Eddie.
Jamal, what a great start to our day. I'm really happy for you. Wonderful lectures. I'd be interested in comments from Ashok, Shane and Jamal on the slow drilling protocol and what their opinions are of it, and perhaps some comments.
How about from me? Because I thought it was a really nice idea, but I still go for success rates of implants. The success rates are really well documented, right? And if we say that you are monitoring your own cases, all right, not selecting your own cases, you will find that it follows what the literature says. It is about 92%. And if you're really, really skillful, you will hit the 96%. But mine is 98%, and it's well documented, and I've drilled at 1200. The implants are all put in at 50 Newton centimeters. And I think that it's all right to drill slowly or whatever and connect your autogenous bone. But the true evidence is everybody's own work. It's working as it is. The new idea seems really good, but I don't choose autogenous bone anymore. And so, xenograft seems to work just as well as autogenous bone. And it is your own experience which shows it. And if we really looked at the collection of cortical bone, well, osteocytes themselves, we know, haven't really got reactivation ability. We know they don't work. They don't turn back into osteoblasts again.
That's okay. Well, Eddie, you and I go back a long way. And one of the researches that we looked at when we started this in 85 or so was sorry? Yes, the and as well as Kirshner, which shows the benefits of internal irrigation. And of course, you mentioned data. Good data is available, I'm sure, through slow drilling, because there are some systems that use slow drilling and have good data. But what actually matters is your working conditions. You saw in my presentation we were using internal irrigation. We use internal irrigation, we use a reasonably high speed. Well, that means that we are able to prepare an osteotomy very accurately and very quickly and in the right direction. Because as you know, every time you insert it and you remove it, it enlarges the hole. So the fewer times, in my view, the insertion of a burr, the fewer times it's done, the more accurate the osteotomy will be. And so I'm committed to using internal irrigation and at a speed where I have some control, where I can drill precisely, and that matters.
I think, Shabal, after you've talked, we should let Nick How to reply to all that.
Not really. Other than the fact it's an alternate approach. It does have its place. I'm not saying that we only use autogenous bone. We use xenografts quite extensively, but the way we apply our autogenous bone to our defects is in a layered technique with the autogenous bone first and then the xenograft on top. We actually use activated fraction 2 to actually make the membrane, but we also use bi-guide membranes to get the same result. In terms of speed of placement, I don't find the actual technique any more difficult. The one thing I would say, though, which you alluded to, is the fact that when you're drilling with a slightly higher speed with certain types of drills, you can control very well the positioning of the drill. But if you actually use those same drills at low speed, the shape of the flutes means that they can snag. I don't know if anyone's encountered that. So sometimes you have to be careful with the design of the drill bits that are used. And in fact, if you look at some of the designs, they're very deep flutes to allow the accumulation of the autogenous bone.
Can I just add? Sorry, I don't mean to. The most critical thing here, in terms of whatever technique you use, is not to overheat the bone. And I think that's the thing. If you use speed, you need irrigation. If you work at a slow speed, you're using slow speed, so you're not very good. It's the 47 degrees for 1 minute that seems to be the critical thing. So
I really think that's very important, because if we're in dense cortical bone, I think slow speed is going to create frictional heat. I think actually in 5 years' time, if we have this discussion, I think many of us will be saying the results coming out of piezosurgery producing our osteophysites are going to be so good that many of us are going to be moving to that. But Jamal, you haven't said.
Yes, I've got very little time left, so I'll conclude with my addition to the discussion. Mechanical and the thermal trauma that drilling will cause is a function of lots of things. It's the function of pressure, speed, torque, and sharpness of the instruments. All these factors affect, but most importantly, what Eddie just mentioned, is the bone density. Bone density has a big bearing on how much heat we will produce over that 1 minute period. So if the bone is denser, you need to use sharper instruments, perhaps a little bit higher speed and a little bit more torque. If the bone is softer, you can step down and make it slower. So I think you just have to be very sensible clinically until we have a lot of data. These are pre-clinical trials. We need to really see real clinical stuff there to modify our surgical techniques drastically, but clearly it's a method to employ in certain selected cases where the bone quality might be soft enough to do it. And we'll bring it up with that fascinating subject and topic which we will revisit, I'm sure. With this, we are going to stop for a coffee break. Nicola, did you have it?
Just add one comment? Now when we look at patient treatment, we not only need to look at success rate, but we need to look at how our patients feel that we have carried out our procedures. And what we're doing at the moment is undertaking a study with this methodology, looking at patient satisfaction. And what we think it's going to show, what the data has shown, is that healing is much quicker and patient satisfaction is better. And I think that's important too when we look at our success rate.
Right, I think with this, we'll stop for a coffee break, 15 minutes, and come back 11 o'clock.